Hello and welcome everyone. Today we'll be discussing on the new updates on traumatic brain injury management. Traumatic brain injury, one is the leading cause of death and disability. The management primarily focuses on preventing or minimizing secondary injury, which is driven by factors such as hypoxia and elevated ICP. Recent updates emphasize the brain tissue oxygenation and a novel approach to chronic subdural hematoma via middle meningeal artery embolism as two major updates that are coming up in the management. Regarding the burden, 190 deaths per day in USA come from traumatic brain injury, and many of those who do survive have long-term sequelae. So the substantial healthcare cost, both intermediate as well as long-term, is because of this disease. Prevention and early treatment are critical for reducing morbidity and mortality. Traditionally, the management focuses on ICP monitoring and its control, maintenance of cerebral perfusion pressure, sedation, analgesia, and hyperosmolar therapy with common intervention. Now, why brain oxygenation? Even when the ICP is normal, the brain tissue may continue to be hypoxic. Direct measurement of the partial pressure of the brain tissue oxygenation may detect this as an early warning sign. So, the goal is to prevent secondary brain injury by ensuring adequate oxygen delivery to the vulnerable tissues. So, we'll come to the recent most important trial that has been published, that is the boost 2. The population here is severe traumatic brain injury, that is GCS less than 8 in adults. They used an intervention that is ICP plus the brain tissue oxygenation guided therapy. Actions taken if the brain tissue oxygenation dipped below 20 millimeters of mercury. In comparison, it was just plain ICP data with blinding to the tissue oxygenation. Outcome was the burden of brain hypoxia, time spent below this PT oxygen threshold, that is less than 20, and functional outcome at 6 months. So there were three tiers of treatment that were given. In tier 1, it was head elevation, sedation, analgesia, CSF drainage, targeting a temperature of less than 38. CPP optimization. In tier 2, CO2 and O2 optimization, neuromuscular blockade, surgical treatment of the lesions, target 36 degrees, hyperosmolar therapy, cerebral autoregulation, and transfusion of PRBC. In tier 3, there was barbital coma, cardiac inotropes, decompression, and a targeting of hypothermia. The results showed reduction in duration and severity of hypoxic events in the tissue oxygenation group, trend towards better survival and lower disability scores, demonstrate feasibility of adding this monitoring as without any significant adverse effects, early termination due to positive interim findings, and a full phase 3 trial was done. So, if you look at the various parameters, the proportion of time below 20 was greater for ICP group, average depth was again greater for ICP group, area under the curve was greater for the ICP group. So, if you look at the Glasgow outcome scales, they were worse in the ICP group, and the disability rating was better with the brain oxygenation. So, regarding other studies of brain oxygenation, you have the OxyTC, that is the France trial, which found no significant difference in the functional outcome with additional tissue oxygenation monitoring, slightly higher intracerebral hematoma rates in the PBT02 groups. The Boost 3, the current trial that is going on, and the Bonanza are two large scale trials which are ongoing, and this may are looking for whether this strategy improves functional outcomes over ICP alone. Regarding chronic subdural hematoma challenge, it is common in older adults. Up to 37% can recur after standard surgery, that is Burr. So repeated procedure carries a risk and prompting a search for less invasive procedure. So coming first to what is middle meningeal artery embolization, it targets the arterial supply to the outer surface of the subdural hematoma. It reduces the inflammation and bleeding within the hematoma cavity and can be performed as a standalone procedure or an adjunct to the surgery as well. So if you look at the key evidence regarding this, multiple studies have shown 50 to 88% reduction in hematoma size and lower recurrence rates. Large retrospective trial with over 500 patients showed 7% clinical failure and may be particularly beneficial for patients with high surgical risk or who are having recurrent subdural hematomas. So the update in management is, according to the Brain Trauma Foundation, is to maintain a systolic blood pressure more than 110 in adults and age appropriate for children, avoid hypoxia, frequent GCS changes, prompt transfer to neurosurgical center, and the tiered approach, that is 0 to 4, integrating ICP and PBT2 for complex cases. So this is called the Mantle algorithm. In this, you try to keep a temperature of around 36 core temperature, hemoglobin 8 to 12, electrolytes level like this, metabolism, oxygenation more than 18, CPP 60 to 70, arterial pressure more than 110, glucose 110 to 180, target oxygenation of 80 to 110 in the ABG, lung protective ventilation strategies, mechanical power less than 17, edema and ICP measures to be done. So the summary of the updates is that brain oxygenation monitoring adds depth to the conventional ICP monitoring. So the embolism strategy being performed in chronic subdural care offers a minimal invasive and durable option. Evolving protocols encourage tailored, tiered management strategies. Large scale trials are on the way, so we will have better information regarding the brain oxygenation soon. Thank you for your patience.